Hello, my name is Dr. Tracy Bone. I'm the Corporate Secretary for the World Federation for Mental Health and a member of the Webinar Organizing Committee of the Women's Mental Health section of the World Federation for Mental Health. I will be your moderator for this webinar, our second in 2021. Before I continue, I'd like to acknowledge the land and territory from which I join you all from, the University of Manitoba campus in Manitoba, Canada. The University of Manitoba campuses are located on original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. As the moderator, I'd like to begin by discussing the details of our program from today, as well as some general housekeeping points. First, given that we do have guest speakers and attendees from around the globe, and that may bring connectivity issues, we have elected to mute everyone's video and audio for the duration of the webinar. If somehow someone has been missed and your video is on, could I please ask you to mute that? With the exception of the speakers, of course, as they will share their thoughts and wisdoms with us with their video on. Regarding the program, as you know, the theme of this webinar is gender-based violence and women's mental health during COVID-19. The Women's Mental Health section of the World Federation for Mental Health is hosting this program. Unfortunately, our chair, Dr. Yuneisa Nayez, is not able to join us today, so she sends her regrets. As moderator and member for the Women's Mental Health section, I bring greetings on behalf of the chair and our entire committee. The committee includes members from around the globe, sharing a common goal of increasing awareness of women's mental health needs around the world through dialogue, as well as webinars such as these. On behalf of the committee, I thank you all for joining us here today. For the program for today, I'll provide a brief introduction to each of the presenters in the order in which they appear on the webinar flyer, and invite the speakers to share their presentations with us. Following the presentations, we'll have a brief question and answer period. In advance of the Q&A, I invite guests to submit questions for any of our guest speakers directly into the chat box below. If you have a question for a specific speaker, I ask that you identify that speaker by name in the chat box specifically. That will make it easier for me then to connect the question with the speaker to which you're directing it. The question and answer will be followed by closing remarks from Dr. Ingrid Daniels, President of the World Federation for Mental Health. Before we move into the program itself, I would like to take a minute to acknowledge the Women's Mental Health Webinar Organizing Committee for their work on this webinar. To highlight the international breadth of the Organizing Committee, our chair, Julie Millard, is from Australia, and committee members are from locations around the world. Portia Poe is from Singapore, Nancy Wallace, the United States, Ingrid Daniels, South Africa, and as noted earlier, I'm from Canada. Our first speaker for today is Dr. Claudia Garcia Moreno. If I could ask all other guest speakers to mute your video, and we will have Claudia's video only, as well as her sharing of the screen. So if I could ask all others to mute their video. Thank you. And one last person, thank you. All right. I will do a brief introduction to Dr. Claudia Garcia Moreno. And then if you could give me 1 minute, I'm going to turn on my timer. I do want to be respectful. Stopwatch, hold on. I do want to be respectful of everyone's time. We have planned 90 minutes for this overall webinar, and I want to ensure that everyone, or that we leave the webinar within that 90-minute time period. So by way of introduction, Dr. Garcia Moreno is unit head in the Department of Sexual and Reproductive Health and Research of the World Health Organization, covering adolescent health, violence against women, and harmful practices. She has over 30 years' experience in public health and global health policy, with a focus on women's health, sexual and reproductive health, and HIV/AIDS. She has led WHO's work on gender and women's health and violence against women, including coordinating the WHO multi-country study on women's health and domestic violence, and co-leading the first global and regional estimates on intimate partner violence and sexual violence against women. She is a founder, past chair, and now in the Leadership Council of the Sexual Violence Research Initiative, and chaired the independent advisory board of the What Works to Prevent Violence Against Women and Girls Research Initiative. She is a physician from Mexico with a master's in science and community medicine from the London School of Hygiene and Tropical Medicine. Dr. Garcia Moreno, I turn it over to you.
Thank you very much. Good morning, good afternoon, good evening, everyone, and very delighted to be here and to see this topic on the agenda. I think although we know more and more about the strong connections between violence against women and mental health, it's still a subject that is very lacking when it comes to the response. I'm going to give you a really quick bird's eye view of what we know about the global prevalence of different forms of violence against women, its health impact, and something about the health system response and what WHO is doing. And okay, just a reminder, because our data is very much focused on two forms of violence against women, particularly intimate partner violence and non-partner sexual violence, that there's many different forms of violence that women and girls experience throughout their lifetime, even though we have limited data on some of them. And also that this violence starts early in life. Girls, we know, are more likely to experience infanticide, neglect and malnutrition, sexual abuse in childhood. And these violences are, the impact of these violences is cumulative and really continues throughout the life cycle. And we need to really understand more about this longitudinal trajectory and overlap of different forms of violence. But starting with childhood, this is some data from the Violence Against Children surveys that are being conducted in many countries by UNICEF and the Centers for Disease Control in the USA. And, you know, without going into the specific, it's just really a reminder that this is still very common in many parts of the world. It particularly affects girls, almost double, you know, than it affects boys. But it's also very important and significant amongst boys. And this really sets the stage for a lot of mental and physical health and developmental problems and challenges. UNICEF has estimated in their report, 2019 report, that there's 120 million young girls that have already experienced sexual abuse by the age of 18. So this really just speaks to the urgency of addressing this also as prevention. I'm jumping from there to the prevalence estimates that we just released on intimate partner violence and non-partner sexual violence earlier this year, which are an effort across many UN agencies, and we also have an independent technical advisory group. And they respond to the two indicators of the SDG target 5.2 on the elimination of all forms of violence against women and girls in the public spheres, including trafficking and sexual and other types of exploitation. So the target is broad, but the indicators are narrow, and they focus 5.2.1 on intimate partner violence, physical, sexual, or psychological, and 5.2.2 on sexual violence. There's other indicators in the SDGs, particularly under goal 16, that around the building of peaceful and just societies that capture other forms of violence, but where the data is less developed and available. apologies, but for some reason I'm not able to now move my slides. Any advice on how to? Okay, just to highlight that these data are based on studies that were conducted between 2000 and 2018. So these shockingly high, prevalence estimates predate COVID-19. And it's important to keep this in mind because we know from many, studies and from what we know about risk factors that COVID-19 is likely to have had an impact on the prevalence, but we won't really know that until we start measuring prevalence again, once we can resume surveys. One of the sad things is that the combined prevalence estimates of physical and sexual intimate partner violence and non-partner sexual violence remained within the 1 in 3 figure that we first put out in 2013. So although there has been growing awareness and growing emphasis on this, on violence against women, we still have not seen a shift at the global level in terms of population prevalence. These are the data for, these are the global prevalence estimates for of intimate partner violence for two populations, for ever married women aged 15 to 49, and for the same population but 15 and above, which is the SDG. The reason why we use 15 to 49 is because that's the majority of the data comes from demographic and health surveys or reproductive health surveys. So it's the age group for which we have the most data. But you see that more than a quarter of women, 27%, 15 to 49, or 26%, have been subjected to physical or sexual violence from a current or former husband at least once in their lifetime since age 15. And when we look at past 12 months, which is the measure for current or recent violence, it's 10 and 13%. Okay, we have highlighted.
Excuse me, Dr. Garcia Marino. Yes. So your slide presentation is not forwarding. We are on slide 7.
Oh, okay. Let me share again and see if it works, because at the moment, okay, I'm going to stop sharing.
And again, I do have a copy, and this is why I asked for a copy in case there were technical difficulties. Yeah, so it has advanced.
Is that okay now?
Yes.
Okay. So we've highlighted that almost 1 in 4, 24% of adolescent girls 15 to 19-year-olds already have experienced some form of intimate partner violence. And 16% of young women have experienced this violence within the past 12 months. So, we think this is a really important to keep in mind, because this is an age group at which many health, including mental health and developmental issues, get set. Relationships are developing, and so we think it's really important to address the adolescent girls, and even before 15. What happens for some reason is that I cannot progress them. Yeah, I'm not able to move them forward.
Share my screen.
That would be great.
Presentation. Sorry, Ingrid, you were going to say something?
Okay, yeah, sorry, Tracy. Maybe if Claudia right clicks on a mouse, the next slide will come up. She can click on next slide, and then usually that would move the slide. If you could try that, yeah. Next.
Okay, I'll do that. Thank you so much. So this is just the prevalence by age group, and you see it's already high in the 15 to 19-year-olds. It remains more or less high across. And in the past 12 months, which is the lighter color, it decreases, but it's also important to know that the age group 50 and above is the one for which we have the least data available for the reasons I said below. These global figures hide huge national, country, and regional disparity. I invite you to look at our website. We have a platform where you can click on any country and it will give you whatever data is available and the estimates. But I think the point I would like to make here, these are WHO regions, is that the high income regions, you know, where the US and Canada, Western Europe and Australia and New Zealand are located, have very low rates of current past 12 months violence, whereas the, whoops, now I've done the opposite, and I've gone completely, okay, previous. I apologize for these technical difficulties. I did try it out. It seemed to work, but no. No. And, you know, if you look at the Eastern Mediterranean region or the African region, Southeast Asia region, you see that the rates of current past 12-month intimate partner violence are very high. And that probably reflects the inability of women to leave abusive relationships, inability to access services, etc. So it's important to keep these differences in mind. When we look at non-partner sexual violence, the overall was estimate was 6%. Very close to the one in 2013, which was 7%, but we see the opposite pattern. We see much higher rates in the high income countries. We think this reflects both better quality data and also probably slightly less stigma and risk of disclosure. But basically what we found was that the measures that are being used for sexual violence are very narrow. They focus mainly on rape and rape with the use of physical force. So they really don't capture the myriad forms of sexual abuse and harassment that we know women and girls are exposed to. So a lot of work to be done here in terms of improving the data quality. I've mentioned already some of these issues, but just to highlight women living with intersecting forms of discrimination. We know that some populations are at higher risk. There's some evidence around women with disabilities, but still a lot of limitations in terms of how little this is being captured. We know in countries where that have looked at indigenous communities, that indigenous women, for example, in Australia and Canada, some Latin American countries experience almost double the rates of intimate partner violence and sexual abuse compared to non-indigenous women. We know that populations of diverse gender identities or expressions of sexual orientations are also experience higher rates of violence. And lastly, we know that these forms of violence increase for women during emergencies, in refugee settings, in migration, displacement. And this isn't just sexual violence, which is what we hear the most about. It's also partner violence, domestic violence, child marriage, that is increasing. A recent study from South Sudan, for example, found that 65% of women and girls had experienced physical and or sexual violence in their lifetime, and a third had experienced sexual violence by a non-partner. This is a region that has gone through a lot of conflict. And also 6% of men had experienced sexual violence from a non-partner. So just to conclude, I mean, the experience of violence, particularly for women and girls, is extremely common, and it's more common from people they know and intimate partners and other family members. And really this has, as we know, a lot of health impacts that are very vast. They're, you know, range from fatal to non-fatal, and they impact physical health, chronic conditions, reproductive health, and importantly, what we're here to discuss, mental health. And there is increasing evidence that the chronic stress is one of the pathways, important pathways, you know, as well as direct impacts on many of these health impacts. This is the data from our health burden study of 2013, where we found that women exposed to intimate partner violence are twice as likely to experience depression, almost twice as likely to have alcohol use disorders. And the same was true for sexual violence. And this is just really the tip of the iceberg. They were 4 times more likely to have experienced suicide attempts. So lots of evidence And just a couple of slides that I have to acknowledge, Lori Heiss, come from Lori Heiss, the next 3 slides. We know that there's a complex and often bidirectional relationship between poor mental health and IPV. And a systematic review of cohort studies from Lorraine Bacchus and colleagues documented that women experience recent IPV are more likely to experience recent depressive symptoms. Women experience depressive symptoms are more likely to experience subsequent abuse. And there's also a strong association between recent IPV and postpartum depression and also maternal depression. In a study that I was involved in South Africa in antenatal care clinics, 3 antenatal care clinics in Johannesburg, where the prevalence rate of recent past 12 months intimate partner violence was 27%, so more than a quarter of the women that were coming through that service had experienced IPV. There were also high rates of HIV, and there was a very strong association, significantly different between women with violence and without, of anxiety, depression, and PTSD, which are the 3 things that we measured. There's also the issue of alcohol and substance abuse. We know it's a strong, that men's hazardous drinking is a robust correlate of perpetration of IPV. We know that it's particularly associated with frequency and severity of abuse episodes. And this association has been confirmed in various studies. The relationship between women's drinking and IPV is less clear. It seems to be particularly, there's a positive association between heavy and binge drinking and lifetime experience of IPV, but this could also be driven by abuse in childhood, which we know is associated also with mental health. So in summary, we know that this is very common and likely to have increased during COVID-19. And we know that it is that people who have experienced all different forms of violence and abuse, women have elevated risk for multiple mental health disorders, including, the most commonly measured ones are PTSD, depression, anxiety, but also there's, studies looking at dissociative disorders of sexual functioning, eating disorders, sleep disorders, and certainly substance use. So definitely an important area to be talking about. At the same time, we know that the health sector response is still very much lacking, both in terms of mental health and in terms of violence. And so we have like a double issue to address. There's plenty of reasons why health providers and health systems have a critical role in supporting survivors and in also reducing subsequent violence and minimizing the impact of violence and in prevention, and for all the reasons that you see in this slide. But we know that it's an area where there are challenges, and also that it's not just about knowledge or information, because it really is, it requires an empathetic response. It requires thinking about safety. It requires, operating in a way that enables survivors to feel more in control and able to make decisions. So it kind of requires sometimes a bit of a change in the chip in the way that health providers have been trained to respond. And this is one of the areas in which WHO is working, obviously. We have some clinical and policy guidelines that we're in the process of updating and some implementation tools. And I'll mention the clinical handbook because it's it's very widely used and translated into many languages. I think partly because it's very simple, very practical. It really provides easy to use tips and job aids. And in terms of the mental health components that are included, we have what we've called first line support, which is really an adaptation of psychological first aid. And I'll show it to you in a moment. And then we have a section, additional care for mental health, which talks about, basic psychosocial support, helping women to identify positive and strengthen positive coping strategies, stress reduction, and then identification of severe or moderate depression and risk of suicidality and other things. So we've included quite a bit on mental health, but we often see that this is an area where there are many challenges to, in the training. This is our first line support psychological first aid, which we've translated into a mnemonic: lives, listen empathetically, inquire about needs, validate, enhance safety support. And that's been translated into many languages. And each of these elements is kind of elaborated in the document. Just a few slides, a couple of slides on some specific interventions around substance abuse and mental health. There is strong evidence that we can reduce hazardous drinking, but moderate evidence that this in turn will have an impact on IPV. But on the very positive side, a recent meta-analysis by Vitz et al. And Laura Murray and colleagues has looked at 30 randomized controlled trials and showed that brief interventions can reduce mental health symptoms when implemented by non-specialists in low and middle income countries. So there's a growth in terms of the availability of, oops, sorry, that was my timer. So I have to finish now, wrap up. There is a growth in the number of interventions that are being tested. Some of them, have been endorsed by WHO, like Problem Management Plus. We're in the finalizing also something called Self-Help Plus, which is a kind of mixed. It's based on a mixture of mindfulness and CBT. So, I think there is a very good momentum in terms of building on some of these interventions. Two more slides, just this one to emphasize prevention. We have a framework called Respect Women, which sort of summarizes the evidence for prevention around these around these 7 strategies. And in the services bit, we want to really build up the evidence around all of some of these mental health interventions because they also play a very critical role in prevention. And lastly, just to say that in 2016, the World Health Assembly endorsed a global action plan to strengthen the role of health systems in addressing violence against women and against children. So, and that means that ministries of health throughout the world, 194 member states, endorsed this plan and have made commitments to address this. And it includes strong references to the importance of strengthening mental health services. And so this is a tool that we can use also for advocacy and for accountability with governments. And obviously this is a multi-sectoral issue, but we want the health system, the health to step up to the plate. Thank you, and look forward to having questions. And sorry, I went in time. Thank you very much.
Thank you, Dr. Garcia Moreno. In fact, you did not go over time because we had allocated 25 minutes to you. So you had a couple of minutes, so that's quite fine.
I thought it was 20, so I was rushing through at the end, but thank you.
Oops, there we go. That's okay. So a couple of things. First off, I found your presentation particularly interesting, given that I'm a professor of social work at the University of Manitoba here in Canada. And interestingly enough, I regularly incorporate a variety of World Health Organization documents into my course and or make reference as a reference site for my students to the World Health Organization. But I must say I was not aware of your clinical handbook. And it's something that I think would be particularly informative for my students. And so I certainly have every intention of connecting to that as I finish preparing for my coursework for the start in the fall. It is interesting, looking through some of the content, some of your statistics are alarming, statistics around the world, and the difference experienced, the differences experienced by men and women and those identifying as women, those identifying as men, etc. So it really is quite alarming. Clearly, there is need for continued interest, continued research in the area, and continued moving forward to find resources that will support addressing this particular issue. So thank you so much. We have elected to leave questions to the end. So I will do that is I see that there have been some people that have put information into the chat box, but we will be leaving questions to the end. So thank you very much for that. What I would also like to do before I introduce our next guest speaker is I'm looking into the chat box, and I'm delighted that some of our participants here have identified where specifically they are from. So I see, let me go back to my chat box. Hold on, I see that we have guests from South Africa. Hello, Lucia. We have Pakistan, guests from Pakistan. Of course, we have Canada, South Africa, etc. So thank you for all the participants that have acknowledged where they are from in attending this webinar. So thank you very much. All right, what I would like to do now is move on to our second guest speaker for the day. So our second guest speaker for today is Nancy Wallace, LMSW. For 35 years, Ms. Wallace has provided international mental health consulting and training to the UN, governments, and civil society. She is a speaker for some of the top corporations, conferences, and organizations globally and throughout the USA. She is the senior representative to the UN for World Federation for Mental Health and has been so for over 30 years. She also founded the UN NGO Committee on Mental Health in 1996 and is a long-standing member of the UN NGO Committee on the Status of Women. As an NGO representative, she provides expertise and advocacy to the UN on mental health, women's issues, human rights, social development, trauma, and disaster response. She maintains a private therapy practice in New York City and is a psychotherapist at the University Settlement Consultation Center for low-income and immigrant clients. She has been an adjunct professor at NYU Silver School of Social Work, teaching courses in clinical practice and international social policy, as well as mental health. Nancy, I turn it over to you. Nancy, you are muted. Nancy, you are, oh, there we go.
Okay. Yes. Can you see my slides, my slide presentation?
We can see it. We can't see it in the slideshow presentation. There we go. Now it's in slideshow. Thank you.
Okay. Thank you so much. I'm so pleased to be with everybody today and to be able to talk about mental health risk during COVID. As Tracy said in the introduction, I'm a psychotherapist, and during COVID, that has been my primary function for the last year and a half, is to really be providing counseling for people. So the mental health impact of COVID has been very evident in my practice. And with the populations that I'm working with. So I'm really happy to be talking about this topic today. So as we obviously, all of us know that COVID has disproportionately affected women in many capacities, primarily, but very significantly for us today, impact on their mental health status. We know that there's a number of factors that have actually increased the impact of mental health problems. Certainly one is the dramatic increase in women's caregiving responsibilities and the stresses that has caused during this time. Also, the women have been the leaders on the front lines in providing essential medical and other services. And have had increased hours of work, and certainly a greater risk of exposure to COVID-19, sometimes due to inadequate personal protective equipment and resources in their work environments, and sometimes safety precautions, and then therefore are bringing greater risk to their families when they return home. We see that another impact has been a rise in what we already know is a pandemic, an epidemic of sexual and domestic violence, which Claudia discussed so well. But the research is showing that there's a significant increase in sexual and domestic violence during COVID, which makes it an incredibly important topic for us to be addressing. There are also barriers which exist prior to COVID, but have been exacerbated during this period of time. Barriers to healthcare, especially pregnancy-related health cares. And for women with disabilities, women show higher rates of vulnerability and mental health symptoms. We know that generally, but particularly during COVID, we've seen a significant increase in that. I also wanted to make a point that women who have experienced sexual and domestic violence are also much more likely to have, as Claudia pointed out, higher rates of PTSD, depression, anxiety, and other mental disorders, which then in turn make them increasingly vulnerable. So this is a particular population that we do really need to be focused on. And when we talk about disabilities, we're not just speaking about physical disabilities, but women with mental disabilities as well. The continued feminization of poverty has also exacerbated by COVID and during COVID. Discrimination due to sex, gender, age, disability, ethnic and racial status. All of these factors have had a significant impact on mental health. And one of these are many reasons, and there are many more reasons that are, this is a complicated problem, but why we are seeing an increase in mental health problems with women. I'm having some difficulty too.
So Nancy, I believe as Ingrid pointed out, you can go to the right of your slide and you should be able to see a series of icons there in advance.
No, I don't have that on the right-hand side of my screen. Hold on 1 second.
Ingrid?
Right click, try right click.
Right click on your mouse, Right click on your mouse and there will be next, and then you can move it along.
Okay.
Okay.
I'm glad I wasn't the only one.
So the consequences that we are seeing during COVID are excessive worries, which is, you know, we don't often put those, you know, we talk about anxiety and depression, but the initial or many women are experience excessive worries during this period of time. And their worries are normal for any kind of crisis or traumatic situation. But during this period, and it's because it's such a prolonged period and an indefinite period of time, we're seeing this as a significant factor in women's ability to function. So we're talking about excessive worries about getting sick or having loved ones getting sick, losing a job, getting laid off, financial difficulties, certainly schooling kids online at home, which I'm sure many of you have experienced, loneliness, despair, lack of control over when COVID will end. All of these things have created this overlay of excessive worrying. And it's something that I am seeing in my practice. It's a significant discussion point, is this ongoing worry, which has other implications. We're seeing unprecedented feelings of stress and anxiety, depression, burnout, and substance abuse or substance use, particularly with opioids, and at least here in the US, that has been reported. The issues around isolation has created a significant amount of sadness, feelings of loneliness, and it comes from certainly the isolation and the inability to access our normal support systems, to be able to get out and be part of networks. We are social animals, and the idea of not being able to socialize and be out in public is very difficult. Certainly the disruption of our daily structures and difficulty that people have in reforming those kinds of structures that work, and a school and other kinds of things, going to doctor's appointments, being able to go out to groceries, get groceries without having to think about things, wearing certain kinds of, having to add certain kinds of, your mask, your gloves, other sorts of protective equipment. Are all disruptions in daily structures. The system breakdown around us of the normal systems in which we function. As I said, the disruption of our normal support networks. We've all got very proficient, or many of us have gotten proficient in using social media, but not everybody has that access to technology or is proficient. In the work that I'm doing, it particularly the isolation and the lack of support and this disruption of support networks is so prevalent in older women, particularly those that don't have knowledge about technology or access to technology, has increased their isolation, and therefore we're seeing significant increase in depression among the elderly. And there's some, during COVID, there was a recent report here in the US, a study that was done, which I thought was quite shocking. The report showed that working women's levels of depressed mood had increased by 83% versus 36% for working men. And anxiety levels for working women had increased 52% versus 29% for their male counterparts. That is such an enormous number, and it kind of gives you a perspective on this difficulty and the vastness of the problems that we are seeing. I think if you all think about yourselves over the last year and a half, and where your moods have been, how you've been feeling, your experiences, I think that we all can relate to this on some level. Along with these consequences, we're seeing a significant increase in sleep problems, headaches, and other kinds of physical symptoms, tiredness, related increase or exacerbation of medical problems, a loss of concentration, irritability, sadness, lower levels of motivation and productivity. So this is the question that I have asked myself, and I ask her, are we prepared to really deal with the mental health consequences? We know that mental health is an underrepresented issue that doesn't often get enough attention. As Claudia had pointed out in her presentation, I think that what we have to be focused on is finding resolution and making sure that mental health has an equitable attention paid to it, along with medical problems and everything else that we're dealing with in the pandemic. So one of the things that I think about is how to empower women to take as much control as they can of their environment, of their situation, to learn techniques in which to help them manage stress, and to create those kinds of structures in their daily routines that help them manage their lives better. I do believe that we need to have an increased mental health services and interventions. which that is generally true prior to COVID, and will exist after we we are done with COVID. Hopefully we will be done with COVID. But this situation has really, I believe, highlighted the inadequacies in the mental health systems, and the inadequacy of services and resources that are available. So we need to be thinking about how we can increase the availability of service. Certainly we need the universal mental health care. That needs to be included in every discussion about the services need to be free. And when we're talking about universal health care, we need to ensure that mental health has parity with medical care. The systems are already overburdened and underfunded. That's been a difficulty that I've seen here in the US and spoken to colleagues from all over the world, where the systems that were already overburdened are now are flooded. And so many people are not able to access services that they need for support for mental health issues. We need to ensure that there's adequate funding and prioritizations by our governments and civil society. And that requires all of us to be doing active advocacy to ensure that mental health is on the agenda and is receiving adequate attention. We need to have increased assessment of needs and data targeting women, girls, LGBTQ, so that we can truthfully understand the depth of the problems that we are facing. We need to be thinking about creative resource development also to help support these issues. We need to think about in workplaces, more flexibility, childcare, how benefits are provided. Is there adequate benefits for mental health provisions? Really incorporating things like the apps that target stress management, anger management, mental health issues that really can help support in the absence of professional mental health services, can help support women with mental health difficulties. We need more access to information and technology. That's been a difficulty in the low-income population that I work with, is the access to technology and the knowledge on how to use that. Particularly among the older population, there is a real lack of information access to technology, and that has really been a challenge to be able to provide ongoing counseling services to people who don't have adequate technology. We are all doing telehealth services and remote services, and that's become difficult. We need to review our policies and practice which limit access to help and support. And as an example, here in the US, telehealth services were not funded or not covered by our Medicaid and Medicare systems. And COVID brought about a change. It took Medicare months before they implemented the changes. So we weren't able to actually do counseling services for several months with our ongoing clients because of that. And there is now an ongoing discussion of whether we should keep these services permanently, or we should be or that, at some point in the future, when COVID is no longer a significant problem, that we will no longer be able to provide telehealth services. And I think that this is the wave of the future, and we need to make sure that we are advocating for the continuation of services like this, so that we can reach women who are living in rural areas or have lack of access to services in their community. And finally, we need to make sure that we include women in all decision making throughout all of the policy decisions that are being made around the issues of COVID. So I just want to put out a call for action to all of us. Changes don't come. We're all very busy with managing our own lives, but we cannot forget that governments respond to advocacy. And we need to be out there talking to our governments on a local level, on a national level, regional, and globally to make sure that our goals and what we need and want to help support mental health services and mental health policies is being taken seriously and being put on the agenda in an equal way to every other issue that we are facing. So I'm going to end here and want to thank you all, and I will welcome questions as we go forward. Thank you.
Excellent. Thank you, Nancy. I appreciate that. You know, it's interesting listening to your presentation because you talked about the impact of COVID-19 on women, and there is research. It's easy to pick up a newspaper. It's easy to pick up a document or go online and hear some of the information about the impact. Do we hear enough of it? I would suggest not. The mental health consequences on women that you talked about, the excessive worry, those are things that we need to be conscious of for those of us that work with clients, for those of us that work with colleagues in a work setting. We also need to be conscious of the health consequences and mental health consequences on women. And I was particularly intrigued by your slide where you talk about, are we prepared? Because it's true, we can talk about what the consequences are, but we also need to be able to think and move forward as well. What can we do now? What do we need to do now? What do people need now? So we need to be able to not only focus on what is happening, but as importantly, what can we do to move forward? So thank you for that. So yes, I see we are looking at your desktop, I believe. So if you wouldn't mind to stop your sharing, Nancy, that would be great.
Oh, sorry.
Yeah, we're seeing your screen.
Got it. Okay.
All right, thank you. All right, so thank you again, Nancy, for that. I am now delighted as well to introduce you to our third speaker. Our third speaker for today is Estelle Sister. And Estelle, I invited Estelle to also forward her bio, and she has done so. And so I'd like to read her bio to you. And this is written by Estelle. My name is Estelle Sister, and I am 34. I was born and raised in South Africa until I left to go to work abroad as an EFL, English as a foreign language, teacher at the age of 24. I lived and worked in the Gulf, Kingdom of Saudi Arabia, in Asia, China, and Latin America, Colombia. As a solo traveler and gender fluid female, I never felt safe or empowered, but rather disempowered and marginalized, as well as infantilized by patriarchal and macho societies. So much so that it aggravated and fed my depression and anxiety to the point of having to return to South Africa to enter a mental health recovery program, first with Triangle Project and now with Cape Mental Health, to address the trauma and harassment that I suffered abroad. Now I am using my voice to empower myself and others. May we take care of the mental health and safety in which every environment we find ourselves. Sorry, I'm going to repeat that last line. May we take care of their mental health and safety in whichever environment we find ourselves. Estelle, I turn it over to you. So Estelle, if you're ready, you are muted. Estelle, are you there? I'm going to close my chat box.
I'm here.
Okay, so if you
Sorry,
could also
just give me a moment. Yes, just give me a moment.
Sure.
So I don't need to share my screen. I will just perform my spoken word, if that's okay. So you don't have to share my screen. Okay. Good afternoon, good morning, good evening to everyone who's joined us today. I would just like to first of all thank Tracy, Ingrid, and the rest of the panel who invited me for today's discussion. I would like to share the following spoken word that's called backtax. Can everyone hear and see me? Is it good, Tracy? The volume is good, everything's good?
Yes, it's good, thank you.
Back tax. We pay too much back tax for our ancestors' debts. Now we carry it heavily on and around our necks. They don't settle their scores to make room for the new generation's fortune so that future generations may thrive and flourish and be fine-tuned. Look at me, single with no dependents, yet I have so many crosses to bear. As I lie awake at night, obsessed with other women's burdens that ring in my ears like alarm bells going off. Like a deafening panic button that has been launched and can't be shut down. I warn them, I give them all of my support. I listen to them and hold space for them so that they can come and let go of all their burdens. That's what back tax does. It's a heavy burden to bear. It's a painful burden to carry. It's generational trauma carried on the backs of our grandmothers, our mothers, and now it's us. We heap and harp up so much resentment that the path just never seems clear. We seem to buy into all the false realities and fears. That's what back tax does. When we pass on this disease to our children, our neighbors, our soul connections, and true friends become forgotten and left behind. Answer me this. How do I deal with my best friend's ordeal, where she gets punched and fed knuckles for dinner? How dare we label her so strong? How dare we ignore our colleague's predicament by softening the blow with pretty words and Bible verses? While we are saying a prayer, she's begging for mercy at the hands of her husband who makes her his slave. He overpowers her and leaves her powerless as he takes out his frustrations on her. Why? Why do we leave our girlfriends who are mentally ill to their own devices and only call them the next day? Why don't we include them in our inner circle anymore once they start to feel like less? That's all they need, to be loved and to belong. Why? Why do we continue to allow this amongst ourselves like we are prison cells? I guess that's what back tax does.
Thank you, Estelle. Thank you.
Thank you, Tracy.
I must say your words made me reflect on a quote from Sam Vida, who once said, "Beautifully crafted words have the power to captivate the mind of anybody." Thank you for captivating us with your words and inspiring our own reflection to change. There's no question words are powerful. PowerPoints are useful and we use them regularly throughout our business. But you have clearly demonstrated that the spoken word is equally, if not more powerful when spoken from the heart. So thank you for sharing with us.
Thank you so much, everyone.
All right, I will move on to our final speaker for today, Dr. Analia Monferrer. And please excuse my pronunciation. I am not able to do that rolling of the R's that is so beautiful in spoken language. I would like to invite Sylvia Raji, board member of the World Federation for Mental Health, to introduce Dr. Monferrer. Sylvia, if you could unmute yourself and with your video as well. So Sylvia, if you are there, you are muted. If you're speaking, you are muted and we cannot hear you. Sylvia, are you there?
Okay. Okay.
We can hear you now. Thank you.
Okay. Thank you, Tracy, and good morning for everyone. And thank you for the great job. I have the pleasure of introducing Dr. Analia Monferrer. Analia Monferrer is a lawyer, graduate from the Lawyer School of the University of Buenos Aires. She has worked in the judiciary for more than 27 years and has served in various positions in criminal courts. She is the head of the Office of Domestic Violence of the Supreme Court of Justice of the nation Argentine for 15 years. She has also been a professor at the University of Buenos Aires, the National University of Lanús, and at the Federal Police Institute. She has specialized in criminal law, criminology, gender, and constitutional law. Please, Dr. Monferrer.
Good morning, good afternoon, and good evening. Thank you very much for the invitation. It's an honor to participate and to be able to share today's day with you. And thank you, Tracy, Sylvia, Claudia, Nancy, Estelle, and Ingrid for this day. First of all, well, I apologize for my English level, but I'm going to do my best to get them to understand me. For the same reason, I'm going to read today's presentation. At first, I would like to show you a short video about how the office works. I try to share.
La Oficina de Violencia Doméstica de la Corte Suprema de Justicia de la Nación deriva los casos de violencia familiar que se presentan a la justicia de la capital federal. También brinda información sobre la red de servicios asistenciales y jurídicos a los que se puede recurrir frente a un hecho de violencia doméstica. Saque un número y espere ser atendido. El trámite en la oficina comienza con un breve cuestionario para ingresar su caso al sistema informático. Una vez realizado el ingreso, deberá esperar para ser atendido por un equipo de profesionales. Los casos serán asignados por orden de llegada. Debe contar con tiempo, ya que la entrevista con el equipo de profesionales tiene una duración aproximada de 2 horas. La oficina cuenta con una sala de juegos atendida por una maestra especializada. Profesionales de la abogacía, la psicología y el trabajo social elaborarán un acta sobre el relato de los hechos de violencia. Dicho relato permitirá a los profesionales evaluar el nivel de riesgo del caso. Si existieran lesiones físicas, un profesional de la medicina las constatará y elaborará un informe médico. Finalizada la atención del equipo, el caso será remitido a la justicia civil y, si corresponde, a la justicia penal. informará el juzgado que intervendrá en su caso y el horario en el que debe presentarse. Deberá concurrir al juzgado para conocer la resolución que la justicia tomó frente a su pedido. Las medidas de protección dictadas por la justicia serán notificadas a la persona denunciada. A partir de este momento, necesitará la asistencia de una abogada o abogado para continuar su trámite en la justicia. El Estado ofrece patrocinio jurídico gratuito en casos de violencia doméstica. La oficina atiende todos los días del año durante las 24 horas. Ante una emergencia, comuníquese de manera gratuita al 911 o al 137.
Okay, and I will share again. Yes. It's okay, the presentation? Okay. Well. Okay. Well, the Domestic Violence Office was created in 2006 by the Supreme Court of Argentina to facilitate access to justice to the people affected by acts of domestic violence, who are in particularly vulnerable situations. At first, the need to create the OVD emerged from the requirements of civil judges with jurisdiction in family matters to have the necessary information in order to adopt protective measures with no delay. Secondly, from the conclusions drawn in an investigation carried out by the Association of Women Judges of Argentina in 2003, which revealed the existence of an under-registration of domestic violence cases in the city of Buenos Aires. The elaboration of the project for the creation of the OVD began in 2004 with the purpose of facilitating access to justice to all citizens. The Vice President of the Supreme Court, Justice Elena Hayton, was appointed to develop and implement the office, which was finally inaugurated on September 15, 2008. Justice Hayton is in charge of the supervision and control of the work carried out by the OVD. By decision of the highest tribunal, the office is accountable of the Vice President of the Supreme Court. In 2016, the Supreme Court was expanded the office services in order to handle cases of human trafficking for sexual exploitation or prostitution. In these cases, the Supreme Court has determined that complaints may be filed both by the victims themselves or by those who are related to them by the family or affected bonds. Thus, the OVD exclusively takes up cases of domestic violence and human trafficking with the purpose of sexual exploitation or prostitution. The OVD operates 24 hours a day, all year round, working from an interdisciplinary perspective. It provides real access to justice to citizens, while it also offers judges a service by supplying them with necessary resources to efficiently perform their judicial functions. It has an interdisciplinary team consisting of professionals in the fields of law, medicine, psychology, and social work, representatives from all professions on duty around the clock. It's precisely this interdisciplinary work that makes it possible to elaborate in only one step, not only a document which will provide a basis for initiating legal proceeding, but also a risk assessment report on the situation, as well as a medical report on injuries. The OVD receives on a daily basis complaints from people who come to the office requiring information and guidance concerning domestic violence issues. It also receives cases referred by police stations, hospital, and NGO in the city of Buenos Aires. Oh, well, I have problems too with the next.
Well, just listening to what Ingrid had said, if you can right-click on your mouse.
Yes, all right. Okay. Well, I'll try. Well, service provided by the OVD, by the office. provide information on domestic violence issues at the local level and on human trafficking with purpose of sexual exploitation and prostitution, takes the victim statement in order to prepare a risk assessment report, draws up a rating record, and performs medical examination if necessary, indicates the possible course of action according to each particular case and makes the pertinent referrals, monitors the follow-up cases referred to other agencies through reports provided by judicial departments. The OBD offers two types of attention services. The first one concerns people who come to ask for general information on the issue of domestic violence, how to prevent it, how to combat it, among other things, and want to know how the office works. The second one is the attention given to the person that requests the assistance of the interdisciplinary team and wants to make a formal statement of a case of violence. In the latter case, the person who comes to the OBD will be assisted by a unit team consisting of a lawyer, a psychologist, and a social worker. During the interview, a written statement is issued, all paperwork being completed for it to be a formal complaint, and a risk assessment report is drawn up. Besides, the victim, if necessary, is examined by a physician who shall determine whether there are injuries, in which case photographs are taken. A risk assessment report allows judges to take immediate protective measures. Once the victim statement is taken, a risk assessment report is drafted by the office lawyers, psychologist, social worker, and medical doctor. Such procedure takes around 2 hours. This report allows risk assessment posed to the victim at the time or she is being interviewed. Therefore, it reduces the re-victimization of the subject by preventing her having to talk about the traumatic experience over and over again. Thus, the interdisciplinary report enables the team to obtain all necessary data in a single interview to prepare not only the written record, which will provide a basis for initiating legal, civil and/or criminal proceedings, but also a risk assessment report on the victim, as well as a medical report on injuries and all the information regarding the victim's situation. Finally, the case is referred to either judicial courts or non-judicial office. Judicial referral can lead to a civil court, family division, or a criminal court. In civil proceedings, the judicial authority evaluates the appropriateness of the precautionary measures provided for in the current law on domestic violence applied to specific cases for a period of 24 and 72 hours. In the context of criminal proceedings, it must be decided whether to initiate a criminal trial and to adopt protection measures for the victim. The mechanism of the office has saved a lot of time, as experience since its opening on September 15, 2008, tells that now courts usually make the decision on any instructions on the same day or the following day, ideally. As the non-judicial authorities, victims are most referred to free legal advice services, psychological or psychiatric service. The Supreme Court subscribed in 2008 an agreement of cooperation with the governmental authorities of Buenos Aires, aimed at establishing a constant exchange of information and data on the issue of domestic violence and to make available hospital services, shelters, which are very difficult to obtain as demand is always higher than supply. The OBD has signed cooperation with other institutions in order to optimize the resources within the city of Buenos Aires. In response to one of the main purposes, the OBD has designed a specific software validated by the United Nations, which provides reliable statistics. This valuable tool offers data related to the volume of complaints made on domestic violence and can be used to elaborate public policies to eradicate that phenomenon. The work done by the OBD since its opening on September 15, 2008 through last June in this year shows that according to the most recent statistics available, 122,899 cases have been admitted. Out of this, 78% have been women, whereas 22% have been male victims. A further distinction of sex, and they showed that 63% of the victims are women, 15% are female children, 14% are male children, and 8% are men. As to the people accused of committing domestic violence offenses, 81% out of them are men, whereas 19% are women. You can see different data. The observed violence suffered by people is psychological in 1960%, physical 61%, economic 34%, sexual 11%, and symbolic 47%. This percentage exceeds 100% because the type of violence often co-occur simultaneously. Furthermore, a process of desegregation of risk level shows that 41% of the cases are cases of the highest risk, 46% of medium and moderate risk, and 13% of low risk. Here you can see data about referrals, so civil courts, criminal courts, legal advice services, and health services. The OVD keeps updated statistics. Data and certain indicators are published periodically in the Supreme Court's website. Since the OVD was created, the Supreme Court has worked coordination action with the provincial judiciaries to address domestic violence issues from a comprehensive perspective. The Supreme Court has therefore signed cooperation agreement with the judiciaries of all 23 Argentine provinces. Nowadays, the OVD is intended as a model which can be adopted, improved, and replicated by other Argentine courts. The provincial Supreme Courts of Tucumán, Santiago del Estero, Salta, Santa Cruz, and La Pampa have already opened their local domestic violence office. In such a way, the office makes possible access to justice for those confronting domestic violence issues and who are currently unaware of the ways in which their cases can enter the judicial system. And for example, about more data, we observe a clear link between the restrictions on circulation and the number of people who come to the office because of COVID-19 pandemic. Wait a minute. For example, in 2019, we received in the office 12,157 cases. And last year, we received 7,422 cases. Because of that, I said a clear link between the restriction on circulation and the number of people who come to the office is concerned. We are worried about that, and this year is more similar because we continue with restrictions in our country. So I think I have 3 minutes more, but it's okay. Thank you for your attention, and I look forward for your question if you like. Thank you very much.
Thank you very much, Nelia. And I see, unfortunately, I had muted myself, so my apologies for that. I was moving some paper around. Thank you for your presentation. I must say I was not previously familiar with your program or the work that you do at the Domestic Violence Office. I'm particularly impressed by the interdisciplinarity and the approach that you use and the availability of your services 24/7. I can only imagine that both the interdisciplinarity as well as the availability alleviate much of the shock and the anxiety and the fear and embarrassment that a person might be feeling as they seek services at such a difficult time in their life. I would suggest that your program serves as a beacon to fill the gaps for those in need. So thank you for your involvement with that. Much appreciated. Now, I am looking at time and it is 8:21, which means we have 9 minutes left. That does not give us a whole lot of time for the question and answer component. If anyone has any questions, if you could please put them in the chat box, that would be wonderful. I see as we look at the chat box, so that Dr. Garcia Marino has shared the World Health Organization guidelines and clinical tools, as well. Stella Estelle has shared a link to the visuals for her presentation as well, for her spoken word presentation. And she reports that it's in Afrikaans, if I'm saying that correctly. But most will be able to relate to the story being told. So she has provided a YouTube video for that. So in these last couple of minutes, if I might ask a couple of questions. One of them, I wonder, Nalia, if you could speak to, one of your slides talked about symbolic violence at 47%. Could you tell us or talk to us a little bit more about what is symbolic violence? And we do have an interpreter here as well to assist.
Oh, okay, Silvia, okay. Marisa, are you there?
Can you repeat your question? Is that your question to Analia Monferrer?
Yes, that's what my question is too. One of her slides reported that 47% violence is identified as symbolic violence. And I'm wondering if Analia can clarify what she means or what the means by symbolic violence.
Ok. Analia, la pregunta es, ¿cómo definís la violencia simbólica?
Sí, perdóname Marisa, sí, había entendido la pregunta, me va a costar decirlo en inglés así tan rápido, pero bueno.
No, pero yo te ayudo.
Perfecto. La violencia simbólica es la que transmite y reproduce los estereotipos y la discriminación en las relaciones sociales. Si querés decir esa parte, yo continúo.
Symbolic violence, yes, symbolic violence is that the one that repeats stereotypes and repite estereotipos
y produce discriminación. Dentro de la violencia, claro, dentro de lo que observamos en los casos de violencia doméstica que llegan a la oficina,
among the cases we receive at our office,
sí, encontramos que en muchas ocasiones
we find that in many cases
las mujeres nos relatan que el agresor, el varón de esa relación afectiva o de ese grupo familiar, las coloca en el rol tradicional que se espera de ellas. Es decir, que la violencia muchas veces es ejercida porque la mujer no cumpliría con los roles esperados de una mujer dentro de la casa.
Yes, okay. What women generally say is that they receive symbolic violence because they do not fulfill the role they are expected to fulfill, and that has been transmitted through generations to be passive. So when they do not have a conduct, they don't have that, they don't act in that way, they receive that violence.
Claro, por ejemplo,
it's transmitted, it's a model over and over again. And it's generally, yes, an example.
Yes, perdón, que me estaba interrumpiendo. Un ejemplo es que la violencia ocurre cuando la mujer no se ocupa, o el agresor refiere que la mujer no se ocupa de los hijos, no tiene la comida lista. Esto es muy común escucharlo.
A most common case is to listen that they receive aggression when they don't have the meals prepared. They are the only ones to take care of the children. So when they cannot do that, they receive this symbolic aggression that has been transmitted over and over years through the families. That is what she calls symbolic aggression. When they receive this treatment because they are not fulfilling the role they are expected to fulfill, to be passive, to take care of everything at home, to take care of the children, to have the food ready, and that's what she calls symbolic violence.
Excellent.
Gracias, Marisa.
Thank you. I think we have time for one more.
Thank you.
Thanks. So I'm going to direct it to Claudia. Claudia, I wonder if you could speak even ever so briefly to some of the new projects that perhaps the World Health Organization and your department are working on. Could you just spend a minute or two with us on that?
Yeah, well, I think that, I don't know how many people are familiar with the MHCAP program, but it's a program from the mental health department to try to increase the availability of mental health care by enhancing the capacities of primary healthcare for all primary healthcare providers to address mental health. I think there's there's the idea that if you don't have a specialized training, or if you're not a psychiatrist or a psychologist, you can't, and the idea is that all primary healthcare providers should be able to address, the mental health issues. And I think the work that we are doing is to try to, on the one hand, integrate mental health considerations and strategies for those providers that are working on addressing violence against women program, and then also to build up the capacities of those that are providing mental health services to understand the dynamics of violence, to understand gender dynamics and how they play out, because I think there's a huge gap there. So yeah, we are sort of targeting both primary healthcare providers, and now we're in the process of developing some training materials for mental health specialists to sensitize them to the dynamics of abuse. And maybe I'll just mention that the World Psychiatric Association, Donna Stewart from Ontario, has developed a series of vignettes on different forms of violence, gender-based violence, for mental health care providers. I can put the link on the chest. It's part of a curriculum to build the competencies of mental health providers. But I think it provides, they can be adapted and used very flexibly, but they're already there, so you might find that of interest.
Okay, excellent. Thank you so much for that. Now I am looking at the time and I see we are at 8:29, so I'm going to apologize. We might be a minute or two over our timeline. I want to share one screen with you for a quick minute. Oh, sorry, did I share that? If I can draw your attention to this slide, to the World Federation for Mental Health, Women's Mental Health section. If anyone in attendance here would like to be informed of future webinars and activities of the World Federation for Mental Health and Women's Mental Health section, please contact Nancy Wall. This is her email address and her phone number. And as Nancy has indicated here on her slide, we need you to be part of a global mental health movement for change to increase our presence around the world and strengthen our collective voice. And we also encourage you to think about becoming a member of the World Federation for Mental Health. I've stopped sharing my screen and I'm now going to turn it over to Dr. Ingrid Daniels, the President of the World Federation, for closing remarks. Thank you for the opportunity to be your moderator. Ingrid?
Good afternoon, colleagues and all participants. I just want to share one slide with you, if I can find it. It doesn't seem to be popping up. Sorry, I just want to close quickly. I know we pressed for time.
Ingrid, would you like me to share the slide? Were you able to find it?
I'm good, thank you. Can you see the slide?
Yes.
Just put it on beginning quickly. So good afternoon, colleagues. I see quite a lot of participants from South Africa. It's really good to see all of you. And a good day to all our participants. Thank you for making the time to be present with us today to really focus on a very critical and important matter, which is really gender-based violence and the impact of this on women, and specifically under COVID-19 conditions. I bring you greetings from the World Federation for Mental Health's board, and I really just want to thank you for being advocates, for being mental health service providers in this very difficult space at the moment. I really want to echo a special word of thanks to our chair of the Women's Mental Health section webinars, Julia Millard. I want to share a special word of thanks with our moderator for today, Professor Tracy Bone, who managed the entire webinar so effectively and efficiently. Thank you so much, Tracy, for taking us and guiding us and giving us the context for today. And to all the amazing presentations that were delivered today, thank you to the speakers, Dr. Claudia Garcia Moreno, Dr. Nadia Monferrer, I don't know if I'm saying it correctly, but Monferreira, to Estelle Seister, to Nancy Wallace, to all of you who really just put the spotlight, illuminated for us the issues, the context, the prevalence, the concerns, the questions around interventions for women who have sadly been perpetrated against. Thank you for your excellent and thought-provoking presentations and specifically your call to action. I was particularly taken aback by the frightening statistics. 1 in 4 young girls between the ages of 15 and 19 years old have experienced intimate partner violence. I was particularly taken aback by the fact that it is such a common phenomena, which is so damaging to women and children. But I think what came to mind as the presenters were presenting the various slides was the fact that men are not immune. They are affected and have also been exposed. In my own country, gender-based violence has been identified as the second pandemic and increased significantly during the COVID-19 period. Africa, as we saw in one of the slides, high prevalences of gender-based violence. And this is a really concerning issue for all of us. And Nancy asked the question, you know, are we ready to deal with this pandemic, this other pandemic? Women have been disproportionately affected, as we know, during COVID-19. We've seen significant increases in gender-based violence during this period. And the vulnerability of women with disabilities was showcased again today. Of concern is obviously the implications for mental health. And so I ask of us today that when we talk about prioritizing mental health for all across the world, that we don't overlook this very critical, concerning area around women who are exposed and subjected to this level of violence. Estelle brought us today, through her amazing word, down to the realities of what the knuckle feels like. And it brought to the fore this intergenerational trauma, but also the intergenerational burden and responsibilities that we all carry. What was wonderful about the seminar today was that we listened to some best practices. And so thank you very much for sharing with us a 24-hour legal system within Argentina, the multidisciplinary approach to dealing with domestic violence or gender-based violence. And for me, it really highlighted the fact that gender-based violence is a 24-hour issue. Often mental health service providers work between 8:30 and 4:30, and this showcased that interventions need to be multidisciplinary, 24 hours long. And so, ladies and gentlemen, I want to also thank specifically Dr. Claudia Garcia Moreno for sharing with us the World Health Organization guidelines and implementation handbook for clinical management. So we have documentation, we have guidelines from WHO to assist us in the management. And there is evidence for prevention. 7 strategies have been presented or is available at the World Health Organization site. So the question remains, are we ready? So gender-based violence is everyone's business and requires our relentless voices to end gender-based violence and provide safety and protection for all women and children affected. Let us challenge the bystanders and the silence, and let us remain united to end violence of all forms against women and children. I invite you to contact our secretariats, and I've left the email address for you to contact us should you have any questions. Thank you so much for your participation, and I want to invite you to join our next webinar. So please watch out on our website for the next notice of our webinars for women in this very difficult time that we are all providing mental health services. Thank you very much for your participation once more. Thank you.
And on that, we officially close the webinar. So thank you all for your time. I did submit in the chat box, if anyone has any suggestions for upcoming webinars, please add that to the chat box and the organizing committee will take a look. So thank you. Have a wonderful day, evening, or afternoon. Thank you all.